So let's make this one quick and easy. This is Geropharmacology. A few slides here. First thing is that I think that it's important to put geropharmacology in the context of overall geriatrics. Sometimes the eyes of geriatrics, sometimes the geriatric giants. I have several talks for the Nursing 666 course, which talk about the geriatric giants. But basically, when you have someone who is geriatric, you need to be thinking about their mobility, their stability. Are they socially isolated? Are they having cognitive issues? Are they having incontinence? Are they having erectile issues? Is there evidence of infection? Are they immunodeficient? Is there problems with nutrition? Are they having problems with sleep? Are they having problems with their bowels? Iatrogenesis is really very related to medications in the elderly. We definitely see a lot of side effects. Once you get to about 5 medications, you're about 90% sure you're going to have at least one substantial side effect. So keep that in mind. And obviously, impaired senses are going to make it more difficult for people to take medications the way that they're supposed to. So we're going to review a few of the physiologic changes that are associated with aging. I don't usually refer to these as normal aging just because not everybody gets them, but they are associated with aging. We'll talk about some ways to avoid some adverse drug reactions. We'll talk about a few drug interactions, and then we'll talk about a couple of things specifically related to the elderly. So polypharmacy is basically taking more medications than the patient needs. There's no magic number that makes it polypharmacy, but again, noting that once we get up around 4 or 5 medicines, we're pretty likely to have some side effects. We really want to keep the number down as much as we can. That being said, if you've got somebody that's got multiple medical problems, they're often going to be on multiple medications. It's much easier to start a medication than it is to stop one. You have somebody that has something, you start a medication. The problem is that once that's gone, we may not even be really sure why they started it. Someone started lisinopril. Did they start it for their blood pressure? Did they start it for heart failure? Did they start it post-MI? Did they start it for kidney protection? It's really hard to stop it because if you're not exactly sure why they started it, you worry that you're going to have recurrence of whatever that issue was. As noted, the adverse drug reactions, I did put in James McCormick's Polypharmacy song, the Bohemian Polypharmacy song, as well as the Med Stopper are in the section for this unit. Having a PCP who reviews everything should help. But often the PCP is in a very difficult position because once a specialist has started a medicine, it's just that much harder to stop it. And you may have a hard time getting a hold of the specialist. The specialist may have retired. Somebody else may be watching it. They may not be 100% sure, but it is a challenge. So physiologic changes. So as people get elderly, they have a little bit more fat, they have a little less lean, therefore drugs that are fat dependent tend to deposit more and leach out a little bit more. Vitamin D, that can be a good thing. On the other hand, there's other medications that it's an issue. They decrease total body water, therefore you do need to be that much more careful with diuretics just because the point at which they're overhydrated versus underhydrated becomes much closer. They have decreased beta sensitivity, meaning that as strange as it seems, they may actually need higher doses of beta blockers as opposed to lower. So again, that's somewhat counterintuitive, but it is something you need to be aware of. People's gastric pH does go up. Whether that's important or not, I think is hard to say, but it can change the absorption of certain medications. Makes it also such that probably putting them on a PPI or one of those kinds of medicines might actually be less important as they age. They often have delayed emptying of the stomach, therefore they have more nausea, therefore they may have more issues. Vaginal atrophy, used to be called atrophic vaginitis, is a common finding, and people do need to be aware of that. There are some medications that we do give vaginally, and those can actually help that vaginal atrophy a lot. and prostatic hyperplasia. The number of cells do increase as men age, and we need to keep that in mind. Now, the GFR does decrease on average, but you have to be very careful applying that to a particular individual, because when you test their kidney function, it may be completely normal. But definitely look at their kidney function. Many people also have decreased hearing, predominantly in the high tones. Therefore, if you lower your voice, they can often hear you better, but it's something to think about. Decreased visual acuity makes it more difficult for them to see their medications, read the labels. Decreased hearing makes it more likely that they'll have misheard whatever you've told them in the office, or maybe what the pharmacy has told them. Wrinkles occur. Decreased elastin is more notable in people that have smoked, but as people age, they will also have skin changes. And probably the most important physiologic change is that the elderly often present atypically. So instead of getting a fever with pneumonia, they just get a cough. Instead of getting chest pain with a heart attack, they get shortness of breath. So it is something that can make it that much more challenging. We often break the elderly into the young old, which are 65 to 75, the mid old, 75 to 85, and then the old, who are over 85. The old, of course, are the ones that are going to be most likely to have these issues that we're talking about regarding geriatrics. We'll talk about it again in a minute, but just to emphasize, a good rule for prescribing in the elderly is start low, go slow. The big challenge is that you do need to go. So if you've started somebody on a medication, you're not getting a response, you need to go up. So if you have somebody who's elderly and anxious or depressed, starting on Prozac 10 milligrams makes perfect sense. Gives them some time to adjust to it, see if they have an effect. But the problem is you can't just leave it there. If they're not getting effect, you have to go up to 20, sometimes 40, sometimes more. So the elderly have many health issues. And the challenge with that, of course, is that when you have many health issues, you have many medications. And when you have many medications, many of them are being metabolized through the cytochrome P450 system. And the challenge is trying to figure out. So when you look at a medicine, you have to figure out, is it a substrate of a particular medicine, of a particular cytochrome P450 enzyme? If you have multiple things that have the same substrate, or substrate of the same enzyme, it'll usually slow the metabolism because you just don't have enough to metabolize it. If you have people that are taking other cytochrome P450 substrates, then you have to decide, if it's a 2DC, are they taking multiple 2DCs? Are they taking multiple 3A4s? And sometimes they'll have things that induce enzymes. So some of the inducers actually increase the amount of enzymes and metabolize things faster. Some of the other things inhibit the enzymes. So a common one to think about is that grapefruit juice is a cytochrome P450 3A4 inhibitor. So it will delay the metabolism because there is not cytochrome P450. If it's a medicine that needs to be converted into its active form, i.e. a prodrug, may not work at all or may work very poorly. If it's a medicine that is in its active form and then needs to be metabolized by the cytochrome P450 system, it may actually stay and be more effective for longer. Hopefully we'll understand all this and have a way to create algorithms and computer programs that look at these interactions over time, especially once we get patients' cytochrome P450 testing done. But right now, it's conceptual. Don't forget that tobacco smoking induces cytochrome P450 enzyme 1A2. And so drugs that metabolize by 1A2, including clozapine, olanzapine, and fluvoxamine. Mostly this is for my psych friends. What can happen is that you can basically have someone who stops smoking. You're no longer inducing this enzyme. The medicines, if they're in their active form, are going to hang around longer, levels will go up, and you'll have increasing effectiveness. Theophylline is an old medicine that we sometimes still use that is also a 1A2 drug, and the problem is that if you have somebody that's on theophylline that's smoking, if they stop smoking, their theophylline levels may go up and they may actually become theophylline toxic. GI issues, the elderly absorb differently very commonly. So a lot of times this is related to the comorbidities that they have. Social issues, they may not take their medications for financial reasons. They may not be eating well for financial reasons. They may be eating the wrong things for financial reasons. Proportion of body fat goes up anyways, whether they're eating poorly or not. And so sometimes you do need higher doses. PPIs and osteoporosis, we've talked about this in class. There is a correlation of PPIs and higher gastric pH. The connection to osteoporosis is theorized, but to my knowledge has not actually been directly established. So kidney issues in aging, on average, the amount of kidney function decreases about 1% per year after age 50, but that may vary enormously from individual to individual. Total body water decreases, and so half-lives of medications may actually be increased a little bit. So remember that the half-lives are published or just sort of estimates, and that an individual's metabolism may be substantially different. Comorbidities, as we've talked about, people that are old because they're old. They're also sick because they're sick. They're not sick because they're old. On the other hand, older people do have more illnesses and more comorbidities. And so when you look at these kinds of things, you have to remember what kinds of illnesses and aging. And so depending on what the issue is, they may have longer half-lives, they may have shorter half-lives. Homeostenosis is a geriatric concept that basically says that the elderly don't have the reserve that young people do. So that if I have the flu and I have to go to bed for 3 or 4 days, I'm going to be able to tolerate it. An elderly person is not going to be able to tolerate it as well because their physiology, the difference between healthy and abnormal, is just that much closer. Adverse drug reaction avoidance. Overall, supposedly the risk is about 20%, according to Medscape. They feel that the cost of these adverse reactions is around $100 billion a year. There's probably tens of thousands of deaths each year. And basically they're saying that we really need to try to decrease the number of medications and try to decrease these side effects. They suggest gradual dose reduction for the majority of people. And basically they're trying to use the Garfinkel method, which says that at least 1 out of 10 currently prescribed medications in the elderly are necessary. That means 9 out of 10 probably aren't necessary. So that if we can get rid of a lot of these medications, we can probably decrease adverse reactions. It is always a balance between the potential benefits of medicines and the potential risks. I tell people all day long, all medicines are magic, all medicines are poison. So start low, go slow. The Beers list is definitely a resource that a lot of us use. There are some people that are critical of it because they don't feel like the science behind it has been validated enough. But at least it gives you an idea of what the standard is nationally. You may or may not choose to use a medication that's on the Beers list, but if you use it, then obviously you're going to be very cautious, you're going to monitor things closely, and you're going to make sure. There is a tool called the Screening Tool of Older Persons Prescriptions, the STOP tool, and it is something that you may want to familiarize yourself as it is a way to decrease the number of prescriptions. The AARP suggests that there's a bunch of medications to avoid. We've talked about NSAIDs, potential risk for GI bleed, potential risk for renal issues. Definitely something you want to use with caution. Can be really useful medications, but also can be very dangerous. Muscle relaxants can cause falls. They can cause excess sedation. Anti-anxiety medicines, especially like benzos or medicines that are very addictive and easy to become dependent on. Sleeping medications, kind of the same thing. Challenge, of course, is that we talked about one of the eyes of geriatrics is insomnia. So many of these people are very bothered by the fact that they can't sleep. Obviously, you try the usual behavioral stuff, that's terrific, but sometimes medications become necessary. Anticholinergics, including things like amitriptyline and those kinds of medications, which are not exactly anticholinergics but have high anticholinergic side effects. Those are increase risk for falls. Benadryl, which is in Advil PM and Tylenol PM and all of those kinds of medicines, has a lot of anticholinergic effects and is, in some people's estimate, the #1 independent factor for falls in the elderly. Different people estimate different factors, but it is something that really should be avoided. So again, people are having insomnia. Sometimes it's better to give them a prescription than it is to have them do over-the-counter medicines. Digoxin is not a medicine we use very often, but it is kind of a twitchy medicine, hard to regulate. Diabetes medicines, Glyburide tends to build up and tends to have problems in the elderly. Most of us, if we're going to use a long-acting sort of second generation, will use the glipizide. Opioids obviously are best to avoid. Tramadol is used a lot more now. Tramadol, of course, has serotonin effects, so you need to be aware of that as well. They mentioned Demerol and Tolwyn. This is actually from a couple of years ago. Nobody uses Demerol to speak of anymore, and Tolwyn is actually an agonist-antagonist similar to buprenorphine, which we used to use but don't seem to use very much anymore. Antipsychotics are relatively obvious. If you don't need them, don't use them. There was a great tendency to use them for people with Alzheimer's disease to try to sedate them and calm them down. In general, though, they tend to have a lot more side effects than the benefits. And estrogen obviously is something that is very controversial. Some people feel it has great benefits postmenopausally. On the other hand, other people are very concerned about the increased risk of cancer and other complications. If somebody's nauseated or confused, definitely go through their meds very carefully because there's a lot of things that might do it. If they've stopped one medicine, remember that the cytochrome P450 issues may have actually ended up with higher levels of other medicines, even though they've been on them for years and years and years. If they've started an over-the-counter herbal medicine, CoQ10, those kinds of things, there may also be cytochrome P450 issues. So what do you do for supplements? A lot of people want to take a multivitamin. If they're not eating well, that's completely fine. Should they be doing calcium and vitamin D? Most people recommend calcium from the diet. I'm actually not a huge fan of calcium just because most elderly people complain that they're big, hard to swallow pills. Vitamin D, we talked about in class. Is there a benefit for it? Maybe. There's probably not a lot of harm. We live very north. Levels are probably low. It's not unreasonable to supplement it. The RDA is up to 2,000 units a day without treating a deficiency, so it's fine to just give a 2,000 daily. Vitamin E, some people do recommend it as a supplement. There's not really a whole lot of evidence supporting it. Vaccines, flu vaccine every year, Tdap. Unfortunately, Medicare doesn't cover this, so you have to come up with some sort of a cut, scrape, bump, or bruise, something that is an indication for a tetanus shot. Prevnar is given at age 65 at the Welcome to Medicare physical, and then Pneumovax is given at the age 66 physical. The actual recommendations are they be separated by at least 6 months, but Medicare will not pay for them unless they're separated by a year. So the Prevnar 13 is the conjugate vaccine. Conjugate vaccines are supposed to be more effective than polysaccharide vaccines, and that's why we do that one first, even though the Pneumovax has the 23 strains in it. Zoster, there's a new vaccine out. The Shingrix seems to be more effective than the previous vaccine, which was the Zostavax. I'll probably talk a little bit about that in the pharmacology update that I'm doing for next week. Other things, aspirin daily, most risk calculators would actually recommend that for men over 45 and women over 55. The ASPREE study cast doubts on this. Again, I'll probably discuss that next week as far as recommendations. Personally, if someone's diabetic, I always do it. If someone's not diabetic and they're over 55, I tend to allow them to make the choice, having them know that there's not a whole lot of evidence that there's much benefit for primary prevention. Statins, unfortunately, by using an age-based calculator, the majority of people that are elderly in their 80s are going to test such that the 10-year risk is always going to be high enough to suggest benefit. Again, I think that this is a complicated issue. The cardiologist will tell you that there is benefit there. There may be some benefit as far as cardiovascular outcomes. The overall death rates, I don't think, have the same benefit that they do in younger people. So just to remind you, when you're dealing with the elderly, especially people over 85, it's really about quality of life and it's about function. What can they do? If you have someone that is on a statin and they ache all the time, you may want to just take them off just to see if the quality of their life is better. Make sure you document very carefully that you had a discussion, they understand the potential risks and benefits, but sometimes it's just worth a try. So keep on plugging.